we'll edit this out, but I just want to make sure. Last name Ephraim?
Ephraim.
Ephraim. Thank you. I'm glad I asked.
Perfect.
Okay, perfect. Awesome. All right, friends, welcome. I'm so excited to do this podcast about Prolapse because it's been a long while and I don't expect my super fans like go back and listen to the podcast from episode 1, but there's like over 200 episodes at this point. There is a very remote Prolapse episode, but it's time to revisit. So I am here with my new friend, Dr. Sonia oh fuck, I fucked it up. Who am I here with? Who are you? Just kidding. I'm here with my friend, Dr. Sonia Ephraim. Do it for me.
Ephraim. Think of fried food. Ephraim.
I love it. I'm here with my friend, Dr. Sonia Ephraim, who is a urogynecologist based in the Midwest out of Chicago, and she does a ton of prolapse, and I do a ton of prolapse, and we're so excited to talk about prolapse today. You did your OB-GYN residency, and then you went back and did a fellowship specifically in female pelvic medicine and reconstructive surgery, and now that's what you do.
Yep. No more catching babies.
No more catching babies. I would have done the same thing.
Yep.
If babies came between the hours of 9 a.m. and 2 p.m.,
it wouldn't be so bad, would it?
I would be all about the babies. The first time I delivered the baby, I was like, the miracle of life. Like by baby number 4, I'm like, oh, they come at 2 a.m. frequently. The miracle of life likes nighttime.
Quickly. Yeah, they like to come really quickly too.
Yeah, totally. Yeah. So, and there's such an unmet need for female pelvic health, female pelvic surgeons. Like, I always say this to be funny, but it's like women are 50% of the population.
Mm-hmm.
It's a lot of people. And we do not have enough, the untreated prolapse, the untreated incontinence, all of that is, I think part of it's just education. And then we don't have enough people to help that out. How did you decide to go to do a fellowship in female pelvic medicine and reconstruction after being, catching all the babies for 5 years after residency?
It was a tough decision, by that time I had a family and I was making a living and supporting my family, but I found that the population I was serving was aging, and I saw a ton of pelvic floor disorders in the office, and I had pretty good training in residency, but there were some big cases that I would have to refer out. And I just got to a point where I didn't want to have to refer them out anymore. And I got such satisfaction from doing the small surgeries that I was doing and seeing the huge impact on quality of life that I was having for women. It was like outside of catching someone's baby and being there for that pivotal moment of life, when you restore someone's quality of life, they were so grateful and it was phenomenal. And the surgeries were challenging. So I just loved it.
I love it. I love the same thing of like, you lift their pelvic floor back up, you change their life. Like so many things get better. Let's define for everybody, what is pelvic organ prolapse?
Pelvic organ prolapse. So that's when your pelvic organs, such as your rectum, your bladder, your uterus, are displaced out of their normal position. I try to explain it to my patients like a hernia, because most people know what a herniation is. It's essentially a herniation in the vagina. So all of that connective tissue that was holding things nice and snug in place becomes weak and things start bulging out, and you can feel that bulge usually protruding through the vagina. And that's when it becomes symptomatic.
I love that because I really think it needs, like, vaginal prolapse needs a rebranding, because so many people come in with shame. Shame that somehow they caused this or that it's a shameful thing. And I'm like, dude, when men get inguinal hernias, which is like the equivalent in men, right? This is a prolapse. Men have prolapse through their inguinal canal because of a weakness. They don't go around saying how shamed they are by it. They're like, I'm a badass because I lifted this thing and I got a hernia, And I'm like, dude, you're a badass because you had a freaking 10-pound baby. Or you're a badass because, you've lived long enough. And like, we just really need a rebranding of prolapse, I think.
Yeah, for sure. I definitely talk to my patients about that because they do. They come in thinking, oh God, did I do something wrong? And I'm like, you know what? It's not your fault. All you did was live a good life, and you had babies, we're not going to tell you not to do that. Of course, there are some modifiable risk factors that we want to talk about, but ultimately, reproducing is one of the biggest risk factors, right? And we're not going to tell people to stop having children. So
yeah,
it just happens from living a full life.
Totally. I think I always joke around with patients. I'm like, blame the kid with the biggest head. And like, they tend to know who that is. They're like, oh, that was
Yeah.
Ryan. Yeah. And like,
Yep.
I was pregnant with my first child. My husband was in front of me and I saw the back of his head. I was like 6 months pregnant. I looked at the back of his head and I was like, oh shit, that's coming through there.
Yeah, I also have a husband with quite a large head. He fits it nicely because of his tall stature. But my children definitely inherited that, and I got blessed. God knew I couldn't handle it. And so I never progressed past the zero station, never passed them vaginally. So vaginal bypass surgery is what I had. Two
Dude, I'm
C-sections
stealing that. That
protecting
is
my pelvic
funny.
floor.
Yeah, well, I put the 10-pound through the vagina. So I'm
Oh,
basically like, all of my friends, I'm like, who's still going to be doing this when I need the help?
right.
But I mean, I think it's super important to normalize. This is incredibly common. Hysterectomy, I think, was or is the most common surgery that a woman has in America, to
Hmm.
be replaced, if not now, in the future, by prolapse surgery because people are living longer and we're taking
Yeah.
out uteruses less. Have you
Yes.
seen that same sort of data?
Yeah, absolutely. I think so many of my patients would come in and have already had a hysterectomy, but now we know out of all the, what, 300 to 400,000 hysterectomies that are done every year, it is a lot of them are unnecessary.
Hmm.
And so we're finding other ways to treat some of these benign gynecologic symptoms and concerns so that we don't have to do hysterectomies. And even with prolapse, right? There's a lot of times that we don't have to do a hysterectomy.
Yeah. Yeah. And just to tie back in, the risk of vaginal delivery for prolapse is higher than the risk of C-section because there is something about traveling through the pelvic floor with your
Hmm.
husband's big-headed sized child. But it's not enough to say that the risks of C-section, because people are like, why don't we just do C-sections for everybody? And it's like, dude, there's
Right.
risks to surgical procedures. Nobody's
Facilitate the
recommending
surgery.
we C-section the whole nation so we don't get prolapse. And I
Hmm.
just want to, clear that up for people to be like, there's still a risk of prolapse, even in people who've never had a child, C-section or not. But
Oh,
we don't
absolutely.
recommend surgical procedures to prevent future prolapse.
Because you're still carrying that growing fetus and that large baby for, 9 months, right? So that's still similar to how obesity is a risk factor. You're still carrying that baby, which is putting all that pressure on your pelvic floor. So definitely a risk, but passing it through the vaginal canal, that exponentially
Takes it up a couple
increases that.
notches in
Yeah.
scientific terms. I mean, the other non-modifiable risks would be age, right?
Hmm.
God bless, we keep living, we keep getting older.
Yes.
The pelvis that your parents gave you, the connective tissue that your parents gave you. I think hormone status is something that we don't have a lot of research on. Other
Right.
non-modifiable risks. I think we should talk about
That's,
modifiable risks.
yeah,
Don't
that's pretty much
get
phenomenal.
constipated.
Constipation is the bane of my existence. The number of women, it's a standard question. Are you constipated? Do you strain? The number of women who answer yes. And then I say, what are you doing about that? Preventive. Oh, nothing. I said, so you just ride that out? Just wait and see if it gets better? You're not
Right?
taking
The fear
fiber
of
or
hemorrhoids doesn't keep you up at night.
nobody feels good when they're constipated. How are you just
Hmm.
walking around like that all day? So we have a
Yeah,
whole constipation handout that I hand out like candy. Like, please read this.
nice. That you hand out like fiber gummies.
Yes.
Um, I love the fiber gummies. I want your cheat sheets. I love the fiber gummies. I love Benefiber. Just throw some
Hmm.
Benefiber in your protein shake.
Yep.
Of course, lots of water. And then, like, to actually get the recommended fiber for women is 25 grams a day, which I say it's like
Hmm.
drinking water. You can't accidentally do that.
Yeah.
Like,
That's
really
very
being,
intentional.
yeah, it's very actually hard to get that much fiber unless you plan it out.
Yeah, with the American diet, nearly impossible. And, I think for women, I've seen a lot of trend towards women doing the intermittent fasting, especially around menopause, because they're trying to control their weight. And if they're eating twice a day, God, that's even less opportunity to get that fiber in, right? So water, fiber, stool. I tell my patients stool softeners every day. It's not going to hurt you. And then throw some magnesium in there. That's going to help with your motility. Yeah, we have a whole cocktail acid. That's what you should be doing on a daily basis. And then maybe if you travel or something, and anybody gets
Yeah.
constipated when they travel,
Yep.
then throw in some Miralax. But to just sit and do nothing, not such a good idea.
Totally. Yeah. And so many people, here's a podcast about prolapse, and we're like, having a nice poop is just lovely.
Becomes more
But
important the older you
it
get.
is. Yeah,
Value those
totally.
little things.
I mean, people, and the older you get, there is some sort of correlation to your age and your interest in talking to your doctor about your poop. Like it definitely goes up
Absolutely.
with age. And, I get to the grand privilege of like being a urologist where I'm like, we talk about your poop, visit's over. And then people keep talking about their poop. Like it's very interesting to people, their own poop. But I'm
Yeah.
like, if you keep talking about your poop, the visit is done. Like
I have to
I
talk
can't,
about food.
I hate it. I
I
have
do a lot.
amazing physical therapists who work a lot on the poop. So I'm like, go to the physical therapists
That's
who
good
are
too.
amazing. Okay, so other modifiable risk factors: smoking,
Smoking. I was just gonna say that. Absolutely.
chronic
Smoking,
cough,
obesity. Yeah. If you've
obesity.
got allergies and you're coughing all the time, please don't just cough. Do something to treat it. Yeah, obesity for sure. Well,
I know we're probably missing like a big obvious one that later on we'll be like, oh right, constipation's big.
yes. Anything where chronic heavy lifting, if you're like a bodybuilder or something, women who are really, really into chronic heavy lifting, doing a lot of squats and lunges with heavy weight.
Yep, that can do it. And we were
Mhm.
talking before we hit record on the role of hormones because prolapse is more common postmenopausal.
Mhm.
And even though you had your baby 20 years ago, 25 years ago, right? The prolapse is now because you're postmenopausal. And the role of estrogen and collagen and estrogen and just how much we lose our muscle mass every year postmenopause with hormone decrease. But I have not seen any papers showing a preventative effect of either systemic or local estrogen, testosterone, all the hormones on preventing pelvic organ prolapse. I have to think there's a correlation because why is it going up in menopause? But I
Mhm.
cannot show anybody those studies. Your thoughts
Mhm.
on that?
Yeah, I have the same thoughts. I have not seen any data on it, but logically it makes sense. We know when we lose the estrogen and we go through menopause that our muscles atrophy, they get weaker and thinner. And so the same thing is happening in your pelvic floor. You can't see it, but it's happening. We can tell when we're doing exams and checking that pelvic floor muscle strength. You see it when they are having worsening symptoms or defecation dysfunction. So it makes sense. It's logical, and
Yeah.
hopefully
Yeah.
it would be that if we replace those hormones either locally or systemically, that it would improve that.
Yeah, I mean, I'm putting the cart before the horse, but post prolapse, just in case we forget to talk about it, post prolapse
Hmm.
kind of protocol to be like, you've got a great repair. How do we help you keep your repair? I do
Hmm.
pelvic floor physical therapy for rehab, and I do vaginal estrogen because I'm like, we
Hmm.
know that it helps with collagen, and it helps
Hmm.
keep the mucosa of the vagina nice and thick. But I can't give you a study to show
Hmm.
to prove that, but just things I think about in keeping your repair once you get a nice repair. Thoughts
Absolutely.
on that?
Absolutely. I hand out vaginal estrogen like candy too. To me, it has so many benefits and so few risks, hardly any that I can think of, that it is 100% worth being on it. And we know that it's going to, like you said, make that tissue stronger. And our support comes not just from our connective tissue, but from our muscles as well. We know the pelvic floor has estrogen receptors everywhere. So I'm going to help with your bladder health. I'm going to help with the vagina. I'm going to help with the microbiome. I'm going to help with everything just by putting someone on vaginal estrogen. Pelvic floor physical therapy, phenomenal. Again, how are we going to keep those muscles strong? How are we going to make sure that you know how to void properly and you're relaxing those muscles, retrain them because surgery is a stress, right? It's a
Yeah.
stress. And oftentimes things get thrown off when we have a little bit of pain post-op. It can throw off how we're voiding and how we're having bowel movements. So I think PT is very important.
Yeah, I always tell my spiel post prolapse surgery is I fixed your bulge, but I didn't make you stronger. So the way
Right.
that you lift, like if your core is weak and you're lifting and pushing out through, the bottom of your pelvic bowl, all those things of like you need to get stronger and kind of learn how to lift, learn how to toilet to help prevent recurrent prolapse.
Mm-hmm. for sure.
Recurrent prolapse after surgery, nationwide, the studies say about 20% or 1 in 5 will have a
Mhm.
recurrent prolapse. Would you agree with that?
Yeah, I think that's about right. And it's, the thing is, it's not always in the same compartment, right? It can be a
That's
prolapse of
right.
a totally different compartment,
Yeah.
but you will see those patients come back with some kind of a bulge symptom later on.
Yeah. Or you'll fix the cystocele and they'll be like, the bulge is back. And I got a big rectocele because they're still
Exactly.
constipated, but they
It's
just didn't
something
fix
different.
that. Yeah, totally.
Hmm.
Dude, this might be a urologist specific pet peeve because I think the bladder is the most perfect organ in the universe. But people come in and I finally have gotten feisty about this, but people are like, my bladder's prolapsing. My bladder's prolapsing. And it bothers me
Hmm.
for two reasons. Number one, the bladder is not trying to leave your body. Like it is not the organ of fault being like, I gotta get out of here, let's go down. Right? So like the bladder is literally not the cause of that anterior vaginal wall prolapse. And the second reason that it really upsets me that people call this bladder prolapse is because
Hmm.
that just means we aren't comfortable saying vagina.
Right.
And
Right.
so many people are like, my doctor said I had bladder prolapse. And I'm like, well, your bladder is descending in your pelvis. Yes, but it's not its
Hmm.
fault. And that's your vagina wall that you're feeling. And doctors just don't like saying vagina, and either do patients. So there's
Exactly.
my it's not bladder prolapse soapbox 101.
I have the same conversation. I
Yes.
explain it to
Like
my
it's not
patients.
just me. Fantastic. Thank you for making me
No,
feel normal.
no. I just had this conversation today with a patient. I was like, it's not your bladder. Think of your vagina like a shelf, and your bladder is a book on the shelf. It's not the book's fault. The shelf is weak and fell down. So it's the shelf's fault. That's your vagina. So, yeah, I try to take fault away from the bladder as well.
Me too. I'm like, it's just a kid in the house, right? It's not the
Hmm.
kid's fault that the house is malfunctioning. like, I'm like, the kid might be unhappy that its home life is not as good as it used to be.
Yeah.
And I tell people that I'm like, the bladder doesn't love living in the basement. You're going to see a lot
Hmm.
more overactive. This is like symptoms of prolapse, right? You're
Hmm.
going to see a lot more overactive bladder frequency, getting up at night to pee, feeling like your bladder isn't empty all the way because it's kind of kinked off a little bit. So I'm like, bladder does not like living in the basement. Bladder loves living in the penthouse, and we're going to get it back there.
Hmm. Oh, that's awesome. I like it.
You can steal it. It's not
I'm
trademarked.
gonna use that one. Yeah.
You can steal it. Bladder loves the penthouse. But I think that's, in talking about prolapse treatments, whether it's physical therapy for mild prolapse or pessaries for non surgical options or surgery, people really are interested and they're like, will my bladder get better? Right. And
Hmm.
I really am careful in sussing out the difference between prolapse and bulge and
Right.
bladder issues. So oftentimes I tell people that the overactive bladder symptoms, the incomplete emptying, is likely to improve. But when I do
Hmm.
surgery, it's to fix the prolapse. Right. We
Right.
can have overactive bladder symptoms and leaky bladders with no prolapse. So really
Right.
some of my education for people is like bladder leakage and behavior is different than like an unsupported vaginal wall or the prolapse symptoms.
Yes. What I'm doing is structural. I'm fixing the structure, putting things back where they belong. And sometimes that overactive bladder right after surgery can get a little bit worse before it gets better. So I feel like setting appropriate expectations is so important on how patients feel afterwards, whether they think you're a great doctor or you don't know what the hell you're talking about. Like, oh my God, what I get into is like, so I set the bar low knowing that I'll overachieve.
Yeah, yeah.
That's my trick. That's why my patients love me so
Yep.
well because I'm like, you might get a little better. And then they're like, I feel great. And I'm like, I knew you would. So set that bar nice and low so they have appropriate expectations.
Yeah,
They,
so talk about what are common symptoms of prolapse when people come in to see you? Like for people, it's like, how do I know if I have a prolapse? And to me, I'm like,
hmm.
laxity of the vaginal wall, incredibly common. Number one, as we age. Number two, as we have babies. I think it's like
Hmm.
30 or 40% of women will have a grade 1 to 2 cystocele after a vaginal delivery. So very,
Hmm.
very common, but not symptomatic and doesn't need to be fixed.
Right.
So just to normalize laxity as we age is normal and common and usually not bothersome. But
Hmm.
then what are people talking about when you start thinking about like a pessary, non-surgery and surgery options for prolapse?
Right. So, if it gets to I always tell my patients that if it gets to the point where it's affecting your quality of life, where that bulge is now uncomfortable, be it you don't exercise like you used to, or you're afraid of being on your feet all day, you have to stop and rest and put your legs up, or if it's affecting your intimate life, where you eat, so a lot of women get body image issues over this, right? They don't
Mhm.
feel like themselves, they don't feel as sexual because of the changes in their body. Once it's causing, it's not usually painful, but
That's
once it's
right.
causing any discomfort, or whether that bulge sensation is rubbing on your undergarments, causing bleeding, irritation, dryness, it's affecting your quality of life, then it's time for us to do something about it, be that non-surgical or surgical.
Yep. Yeah, absolutely. I'm very careful with pain because you can have pain in your pelvis for many, many reasons. And
Mm-hmm.
oftentimes it's not the bulge's fault. There's either pelvic
Mm-hmm.
floor dysfunction, hip issues, nerve stuff going on that's not because of the bulge. And that's a very important thing to talk to people about because they'll get their bulge fixed and not have the pain get any better. Certainly you'd see
Right.
this, with people who are like, I need my uterus out for my pain. They get a hysterectomy, they still have pain because it
Exactly.
wasn't the uterus's fault.
And that's
Um,
the thing about us setting the appropriate expectations, right? And sometimes with those patients with pain, I will strongly encourage them to try a pessary first. Like if it's the bulge and we wear a pessary for a little while, that pain should get better. If it doesn't get better, it's not the bulge. We got to find another reason.
yeah, I love that. It's like a risk-free trial of what surgery
Mm-hmm.
might get you is absolutely brilliant.
Mm-hmm.
So let's talk about a pessary for a second. What is it? Why might somebody use one? They've been around since like documentable history, like
Yes.
pomegranates and fruit back, 2000
Yes.
years ago were the pessaries because we didn't have silicone.
Exactly.
We didn't have,
Exactly.
computer printing.
Yeah, there's
There was
some
just an
nice
article about like personal pessary using 3D printing. Did you see that?
I did not.
Yeah, the future of
That
pessaries
scares
is
me a little
here.
bit.
Right? Like I don't know, you put your pelvis in an MRI and then they 3D print you a pessary or something. I
Wow.
know. That's not going to be $60.
No, no, not easily accessible for
That's not going to
anyone.
be covered by Medicare, my friends.
No. And
Okay, so what's a pessary?
so pessaries are usually made out of silicone. They're little devices. They come in different shapes and sizes, and it's a non-surgical way to reduce your prolapse. You put it in the vagina. A lot of women, when I describe it to them, they're like, "Oh, like a diaphragm." Kind of. It's just something you stick in the vagina and it pushes everything up. It doesn't fix anything, but it reduces the prolapse and resolves symptoms of the bulge, the pelvic pressure. The one caveat I always tell people is it may reduce your prolapse. You may end up with some incontinence that we didn't know about because as the prolapse pulls everything down and it kinks the urethra, the tube we pee out of, oftentimes that urethra, that kink is protecting women from incontinence, right? And so when we push everything up, yeah, the bulge is gone, but are you going to be okay with a little bit of leakage? Risk-free
Yeah.
trial. We can take it out if you hate it, but it's a nice caveat just to let them know that that could happen. And there's so many different sizes and shapes that are used for different varying degrees of prolapse. So there's lots of good options for that.
Yeah, you bring up multiple good points there. You can go on Amazon and buy a pessary, but it's not fitted towards for you. And so that's why I
Mm-hmm.
always say, get it fitted by somebody who knows what they're doing because just getting one off, it's like buying a leg brace, an ankle support of like, it might not fit. How do you know you're a small? Right, you
Right.
don't unless you get fitted. So that might be my first advice. That what we call de novo stress incontinence. So when you
Mm-hmm.
fix your prolapse, now you leak more. That doesn't mean that the pessary or the surgery caused leakage. It means you always would have leaked had you not had prolapse that kind of masked it.
Right.
And so that's always, those are very disappointed patients if you don't counsel on de novo stress incontinence after pessary or surgery. Like, no, you
Mm-hmm.
would have always had that had you not had your prolapse to begin with. But now we have to address that. And they thought for a while that we should just throw slings in everybody when we fixed their prolapse to help prevent that risk from happening. But they said, risks of mesh in everybody is not worth it. Just
Mm-hmm.
counsel on de novo stress incontinence and deal with it if it happens afterwards.
Yeah.
Any comments on that?
I think just one other thing about the pessaries and buying them on Amazon or doing your own thing is I have seen far too many complications of pessaries in my career. It is pretty low risk when managed appropriately. But if it goes unmanaged, I've had women who forgot they were in there and had them in there for years, and I take them out and there's fistulas. They come in because they're leaking urine or stool because they've got an abnormal hole between the bladder and the vagina or between the rectum and the vagina. I had a partner that one migrated all the way through the posterior cul-de-sac and was sitting in the pelvis. She had to have a laparoscopic surgery to have it removed. And so we see people get ulcers and granulation where it's, pressing on that vaginal tissue too hard. And as we get older, that tissue is weak, right? So it causes like ulcerations on the tissue and they have bleeding. So it is very low risk when managed appropriately, but I put people on pessary contracts in my office. Like if
Interesting.
you're not going to come back and let me check this thing, I'm taking it out and not giving it back to you because
Yeah.
I can't take the risk that you're going to disappear into the world and come back with a fistula. I've
Yeah.
seen it happen.
Yeah, it's devastating. I've heard of it happening, like my mom's friend
Hmm.
or something, but I knock on freaking wood. I have had to take a patient to the operating room to remove one because she left it in for years and then, got narrowing of the entrance of
Yes.
the vagina. It would not come out awake. But that's as bad as I've seen it. And we're not saying this to deter people from non-surgical options. We're just saying
Oh no.
everything comes with a risk. Not treating your
Yes.
prolapse has risks, right?
Right. I just
So
encourage, like you said, make sure you get it fitted with a professional and make sure you understand that you need to take it out and wash it every now and then. Maybe you
yeah.
need to leave it out overnight to give your vagina a break every now and then. Just manage it properly. And then, am I still there? Can you hear me?
Yep, I got you.
Okay. And then also, with the incontinence too, I counsel my patients that this could happen. We try to do some testing to see what would happen. If they were wearing a pessary and they were leaking, then I know, okay, we should probably do some sort of support of your urethra,
Yep.
and just give them that option as to what they want to do.
I love it. Yeah, another metaphor I use for pessaries is like, listen, I've got a weak knee and I like to wear a brace when I ski. I'm not at the point of needing surgery for my knee yet, but I just need a little more support. And I think
Hmm.
that sort of metaphor helps people understand like, yeah, I'm not ready for surgery or I don't want the risks of surgery, but I need a little more support. I'm going to choose a pessary. And so I have some people, they just use it with exercise, right?
Yes.
Or they'll take it out. They're like, can I have sex with it? I'm like, I think it's a lot of cooks in the kitchen.
Yeah.
I think a lot of people take their pessaries out to have sex. But just to clarify for people, you can be sexually active with prolapse. You aren't going to hurt it. You're not going to make it worse by having intimacy with prolapse. I think so many people stop being sexually active with prolapse, and if you're comfortable, there's really no reason that you need to be, from a medical standpoint, not be sexually active with prolapse. Anything you want to add about sexual activity and prolapse?
Only that the same as you said, I think that women need to be reassured that they can. Their partners need to be reassured that they're not going to hurt each other. You can, and it's actually pushing it back in, which might be a good thing. So intimacy is perfectly fine. However, like I mentioned before, a lot of women do have some body image issues, which prevents them, in addition to just the fear that they're going to hurt something. So reassuring them is very important. And even after they have a repair, if they choose to do that, helping them to get back on the horse, so to speak,
Hmm.
is very important. I have a sexual wellness coach that I collaborate with sometimes, who my patients, if they are having some trouble just kind of getting over that fear, I have them do sessions with her just to kind of get their sexuality back.
Amazing. I love that.
Mhm.
That's so comprehensive of you. Thank you
Mhm.
for doing that. Yeah, absolutely. Physical pelvic floor physical therapist. We can't have a prolapse talk without talking about pelvic floor physical therapy. I think for mild cases, or if it's not that bothersome and I want to know what I can do so it doesn't get worse, I think pelvic floor physical therapy is amazing. If people have access to that, I think it's so much more than Kegels, right? It's your core strength, your lower back strength. How are you lifting? How are you pooping? Like, really, a
Mhm.
comprehensive pelvic floor analysis can go a long way with
Mhm.
prolapse. Certainly, if it's stage 4, which I describe stage 4 as like it's in between your thighs, right?
Yeah,
We can't anti-gravity all of that with Kegels. So I think there
right.
is a point where physical therapy is not going to be able to reduce it, but especially for the rectoceles, the 25 grams of fiber a day and pelvic floor PT can really make a lot of backside of the vagina, what we call rectoceles, asymptomatic. So that's
Hmm.
quite nice. Rectoceles tend to be trickier with pessaries as well.
Yeah.
So I think pelvic floor physical therapy treating constipation can be good. Anything else you want to add on non-surgical options or pelvic floor?
No, I think pelvic floor physical therapy is great. Patients who are trying to kick the can down the road, they don't want to have their surgery yet. Definitely with the rectoceles because pessaries tend to push those, or rectoceles tend to push pessaries out. They don't
Mm-hmm.
stay put so well. And again, just like lifelong strengthening and keeping your pelvic floor healthy, you can never go wrong with having pelvic floor physical therapy on its own or in addition to the rest of your treatment plan.
Awesome. Um, all right. Well, let's get into surgery because that's what you and I do.
Mm-hmm.
If
Yep.
you are symptomatic, maybe the pessary didn't work. Maybe you don't want to freaking. I ask women, especially like the younger women, I'm like, do you want this for the next 40 years? Right? Because they
Mm-hmm.
don't really think like if you choose pessary, like that's managing a pessary for 40 years versus,
Mm-hmm.
getting it fixed and which is quite safe outpatient surgery.
Mm-hmm.
So let's talk about the different surgery options.
So, my conversation with patients goes, everywhere from the most conservative to the most invasive. And honestly, the surgical options depends on a lot of things. What is their health status? How physically active are they? How sexually active are they? Do they have a partner? Is intimacy important anymore? So you can go anywhere from a reconstructive surgery to put everything back where it belongs, where you have a nice, normal, functional vagina at the end. And if vaginal penetration is important, then you want to do that. Or the other branch of the tree is obliterative surgeries, right? Where we essentially close the vagina. Very wonderful surgery in that it's extremely low risk, it's extremely effective, but only good for women who know that vaginal penetration is not important to them anymore. So you have to, that's kind of the first conversation I have, depending on their age and whatnot, is okay, are we trying to give you a functional vagina back, or are you done with it and just want to never have to deal with this prolapse ever again?
Hmm.
And then when we go into they choose reconstruction, then we have some nice minimally invasive options. And then we have more invasive, the minimally invasive things like a vaginal extraperitoneal colpopexy, a hysteropexy, where we're putting the uterus back where it belongs if you have a uterus, or a sacrocolpopexy, where we're using a mesh to strengthen the procedure. Are we doing mesh-based procedures? There's so many options.
There's so many
But I find
options.
most of my patients, so many options. We can make anything to fit what your goals are. Even recovery, like, oh, I'm young, I have this prolapse that's bothering me, but I have this job that I can't afford to be off of work for 6 to 8 weeks. So, okay, well, let's find a surgery that's going to work for that and give you a shorter recovery. And there's some wonderful new hysteropexy procedures like the end place procedure that we're doing that gets you much quicker recovery, less downtime, less blood loss, less pain, so that you can get back to normal everyday life.
Hmm. I love it. I think what I want people to know is there's so many different ways to skin the cat proverbially, but there's probably one that's best for you, but really to be talking to a surgeon who does the surgeries and can really tailor that. Is it your first prolapse repair? Is it your second prolapse repair? I'm going to think about people
Mm-hmm.
differently that way. Is your apex or top of your vagina well supported, or is that cervix really the first thing I see when I'm doing a physical exam? Is your uterus
Mm-hmm.
big? Is your uterus atrophic? Do you have a uterus? Right. So there's really so many different things that go in. This is why it took us so long to train to be able to do our jobs, right? It's really individualizing things by and large. Most if it's not your first if it's not your a repeat prolapse repair, so if it's your first one, people tend, and I'm overgeneralizing, they tend to want to stay out of the abdomen. They tend to not be interested in big pieces of mesh. Most
Right.
women have heard about the risks of was vaginal mesh, and
Mm-hmm.
so even a sacrocolpal or even a robot sacrocolpopexy with mesh, they tend to shy away from any sort of mesh.
Mm-hmm.
Um, so really, the vaginal approaches are going to, that risk of not having mesh.
Yeah, absolutely. I agree. And, one other thing about the surgery and finding a provider, a surgeon who can do this, like you touched on, so important to make sure you go to someone that can do all of the procedures, or at least is willing, if they can't do it, at least willing to refer you out if they know that you would be better off with something that they don't do. I find often women come and maybe it is their second, but they had one surgery by someone who said, "Oh, this is the only thing that I can do for you."
Mhm.
And to me, that's a disservice to women. I like to be able to educate them on absolutely everything. And then, heaven forbid, I can't do it, I'll send you to someone who can.
Yeah, that's how I am too. I mean, I've stopped doing robot mesh, sacrocolpopexies, but I have friends who do them and they're high volume
Hmm.
surgeons. And my opinion is if you're going to get mesh in the abdomen, do go to somebody who's doing a lot of it. So
Right.
I chose to say, I'm super good at the vaginal based repairs, but if you're
Hmm.
getting into I've had mesh before or I've, failed the vaginal approach, then I know that I'm going to want to refer you on to get to that
Hmm.
high volume place who does those complex failure mesh based repairs.
Yes, absolutely. Absolutely. But yeah, I love vaginal surgery. I think it's a dying art. It's like it's my happy place.
That's
I
sad.
love,
You think most people are getting trained robot mesh based as
I
first
think
option?
they I think they are. I think
You and I
so
are of
many
the same generation.
people, yeah, so many people are jumping on that robot, and the way it has been branded and marketed to the public, it's almost like patients hear robot and they think it's
I think it's
better.
better.
Yeah, and it's like,
Yeah.
no, it's just another instrument. It's like my scalpel. It's like
Mhm.
anything that I use. It's depends on who's using it, first of all,
Mhm.
and it's not actually doing the surgery.
Right,
There's a
right,
person.
right. We're not putting quarters into the machine to have it do it for us so we can drink coffee on the side. Like that would be
Yeah,
sweet,
there's a
but it's never
person
going to
behind
happen.
there.
There's a person.
Yeah.
Yeah, and it's
Yeah.
through the abdomen, right? Higher risk
Hmm.
of bowel complications, and we're putting mesh in
Yes.
there with robots, by and large. So there is an increased risk when you add mesh, go through the abdomen versus the vaginal. I mean, I like vaginal. It's outpatient surgery.
Yes.
You get to go home. We could do this in a surgery center.
Go home much shorter, right? Some of those robotic cases, 3, 4, 5 hours, depending who's doing it. And you're in this steep Trendelenburg with all that gas. It causes complications afterwards. Where a vaginal surgery, man, I can be in and out 45 minutes to an hour, depending on like if I'm doing hysteropexy and a sling and making the introitus appropriate GH size. Like it's so much quicker and there's more finesse, I think.
I
But
love
I'm
it.
biased. I like it.
Yeah, totally. Tell me, because you are a gynecologist, so you can take out uteruses. I'm a urologist, so I'll always involve my gynecologist to do a combo
Hmm.
surgery if we're going to. How do
Hmm.
you counsel a woman or think about uterine sparing versus hysterectomy with a prolapse repair? Can you talk us through your thoughts on that?
Yeah, I think most of the research that I've seen shows that most often taking the uterus out does not improve your long-term outcomes. So you're having a longer surgery, more risk of blood loss and complications to remove the uterus. Now, if the uterus is large and bulky or the cervix is very large, I will counsel the patient that a hysterectomy at the time of prolapse repair is probably appropriate. But I have found that even vaginal hysterectomies, it's not like I used to do. I used to do a lot of them, and now these new surgical techniques, you don't really have to take a lot of people's uterus out. So I just counsel them, you got a really small atrophic postmenopausal uterus. That baby can stay right where it is, and go up and be beautifully supported with a hysteropexy.
So hysteropexy, just to break it down for people, uterus being pexed or basically put back in to the pelvis.
Yes,
Definition of
absolutely.
hysteropexy. Did I get that right?
Mm-hmm.
Yeah.
Mm-hmm.
Versus hysterectomy is removing the uterus.
Right. So uterine sparing versus a hysterectomy.
Yep. Also, I think, female, just because of the nature of this podcast, female sexual health in pelvic surgery has by and large, I think, been underserved or ignored.
Mm-hmm.
In some people believing that the cervix does not play a role in sexual function. The studies don't support that. The cervix isn't a sexual organ for everybody, but for some
Mm-hmm.
people it is. And
Mm-hmm.
another reason to think like maybe I want to preserve the cervix in any sort of prolapse procedure might be sexual function for people. But if you don't bring that up to your surgeon, they're not going to know that that's an important thing for you.
Right. They won't think about it. And, my opinion too is sometimes if it's not bothering you, why am I bothering it? If that uterus isn't hurting you or doing anything, I'm gonna leave her right where she is. And then also with the sexual wellness, not every surgeon is as conscientious about not taking vaginal length when they take the uterus out. So sparing vaginal length for a woman, because that we know definitely affects sexuality and our ability to accommodate penetration, right? So you
Hmm.
don't want to have a short vagina, or especially if I have patients when I do my measurements before surgery and they already are right at the cusp, maybe their vaginal length is only 7 or 6.5. I do counsel them, hey, when we're talking about your surgical plan, let's talk about how much vaginal length you might lose. Even if I'm as good as possible about leaving it, you're scarring, the tissue contracts, you might have a shorter vagina afterwards. Do you have a partner? Is he endowed? Like, what are we dealing with here? So it's definitely a conversation that we have to have.
Yeah, I mean, I think it just again reiterates like everybody is individualized, thinking that there's a one size fits all for all pelvises. And I see that all the time, right? Because why do women tend to come to the doctor? It's because their sister had X, Y, and Z, or their friend had X,
Mhm.
Y, and Z. I see it all the time. People are like, "Can I get Botox for my bladder? My friend had it." I'm like, "You do not even have that problem. Like, just because your friend had it does not mean you should get it too, right?
Yeah.
Everybody's so individualized." When you do so, when I do vaginal surgeries, I do what they call a sacrospinous ligament fixation to re-lengthen the top and the apex, or what they call level one support, back into
Hmm.
the pelvis. How are you working with the in place device with your hysteropexies? Is it the same sort of concept, or is it a little bit different? Please share with me what's
Yeah.
happening.
Yeah, it's absolutely, it's the same concept. You are giving that level one support at the level of the sacrospinous ligament. It's a bilateral procedure. I know back in the day they used to do these unilaterally. Um, I don't know, maybe something about that bothers me having a lopsided vagina, but yeah, so it's, the attachment points are the same. And the one benefit of it is, I do the vaginal extraperitoneal colpopexy all the time. With the end place, I don't have to do that extensive dissection, which is wonderful, especially if you have a patient who's maybe had some surgery before, or she's got a really, really tight introitus. It's very nice to be able to put those points of attachment directly through the vaginal epithelium. So you're really just putting a dart right in the same position on the sacrospinous ligament, right through, without having to do an extensive dissection. Decreases your blood loss, makes the surgery faster, less incisions to heal, so less pain. It's really a very slick procedure.
Can you do this in place technique if you don't have a uterus?
So I do it on anyone who has a cervix because the point of attachment
Cervix. Okay.
after, yep, if you still have your attachment at the sacrospinous ligament, and then you're going to bring that suture up and anchor it into the cervix. So if they've had a supracervical hysterectomy, then I will still do the procedure.
Oop. Are you there? There
I'm
you are.
here.
Okay. It's the end place is for if you have a uterus or cervix, if you've previously had a cervix bearing hysterectomy.
Correct.
Okay, that makes sense. I love it.
Hmm.
Yeah, and I think these are really important conversations because so many women they fear surgery because they think this surgery is going to be like really risky, really dangerous. How many days am I going to be in the hospital? What's my downtime going to be? And really realizing that the modern prolapse repair is usually outpatient. Blood loss is very minimal. Certainly,
Hmm.
there's always risks of pain, infection, and damage to surrounding structures in any surgery that we do, whether it's your toe or your ear or your pelvis. There's always
Absolutely.
risks. But really, I think what women's view of what these surgery is much bigger than really the minimally invasive techniques that we have now.
For sure. Like I said, I get with the end place, I can be in and out of the operating room, and if that's the only thing that I'm doing, it's a 30-minute procedure, and they go home the same day. I've had one failure, and it was a woman who felt so good that she did not follow my post-op and the anchor.
Hmm.
We let her heal and recover, and then I repeated the same procedure again.
Okay.
So that's the nice thing too, is that you can repeat it. And the
Hmm.
next time she's like, I know I did it. I'm so sorry. So I'm glad you feel good, but can we slow down
Right?
just a little bit?
I know. Well, that I mean, I see that so much, right? It's like these procedures are so minimally invasive. Pain is our body's way of saying not yet, right?
Yes.
And they don't have pain, and so they're like, I could probably do this.
Yeah. Yeah.
What sort of vaginal rest for the end place do you have? What's your standard to say, hey, you can resume physical activity after our post-op exam at what week?
I do a standard post-op exam at 2 weeks. I tell them they can get back to normal everyday activity, barring like super heavy lifting or penetration, at that 2 week appointment. I'm super conservative about my restrictions. I know the research shows they can probably get back to normal activity in 3 to 4 days, but I'm still very conservative. And I make them wait 6 weeks to have intimacy,
Mhm.
just to be cautious. I want to
You
make
want it
sure
to
that,
go well, you
yeah,
know?
I want it to go well. I want them to be happy, and I'm like, you can wait. I promise you, it'll still be there in 6 weeks.
Right, right, right. Yeah, that's super sweet. I love it. Um, Anything else that we missed or didn't talk about? I think we covered, we didn't say the word for obliterative. So if we close your vagina top to bottom, we close it. That's called colpocliesis. And even my staff
Mhm,
can't say that word after working with me for years. It's a tricky word, but basically, closure of the vagina is colpocliesis. And then there's
mhm,
vaginal based repairs, which we've just been talking about, uterine sparing or hysterectomy. And then there's the abdominal with mesh, which is the robot sacrocolpopexy, which again, big word, but basically lifting up from inside the abdomen instead of pushing up from the vagina is the other approach. Did we miss any big things as far as surgery goes?
I don't think so. Those are the branches of the tree.
We did good. And
Yeah, I
sometimes,
think.
if we have significant stress incontinence, which is separate
Hmm.
from prolapse, you can add a sling on at the same time.
Hmm.
If you're already, so there, that would be, I think, the other nuance to getting prolapse surgery is, do you need a sling for stress incontinence?
I think we touched on too, maybe that it's different compartments of the vagina. You have the
Yeah.
posterior, the anterior, the apex. Any one of those compartments could prolapse, and so your surgery is going to be based on which compartment of the vagina is actually prolapsed. We don't do preventive or prophylactic repairs. So that if I'm in there doing a rectoseal and you're like, well, can you just do the anterior wall too? No, it
No.
doesn't work like
If it's
that.
not there to fix, you can't fix it.
Yeah, yeah.
Yeah, I see that a lot. It's interesting, just to get a little more nuanced. Like, I think cystoceles are the number one bothersome prolapse, at least in my practice. And if people have a little backside laxity, what we call a rectocele, but it
Mhm,
doesn't bother them, they're pooping good, they're not splinting, I will not fix it, especially if they're sexually active, because I don't want more
mhm,
scar than necessary. I don't want more
mhm.
risk of pain with sex than necessary. If you have a little laxity, but it doesn't bother you, I don't tend to fix it.
I agree. I agree.
Yeah,
Less incisions, the better, because
totally.
you can always do physical therapy, and help with that. But if you're not, like I said with the uterus, if it ain't bothering you, I'm not bothering it. So let's just leave it alone.
I really like that. Yeah, I mean, the other thing, and I think, what we are both saying is like, go to a surgeon who's not in a hurry to do surgery. Like, how many people come to me because people got their pap smear and they were told they had a cystocele, right?
Yes.
Or the new popular thing is they got a deficogram because of bowel dysfunction, and an imaging report says you have a cystocele, but
Hmm.
nothing bothers you. I make you stand up and squat, and nothing comes out. That is
Hmm.
not surgeons are like, I can fix the bulge that's there, but I can't
Hmm.
fix something that somebody said you had that doesn't bother you, or that an X-ray said you had, because that's
Exactly.
not the same as like a bothersome problem.
Hmm. I agree. I think I've had such great success in my career because I don't bother things that are bothering people. I only fix what the problem is, and I
Yeah.
give, it's about the counseling, the appropriate expectations. customizing the surgical approach to each individual woman, and only fixing things that are actually causing a problem.
I love that. Yeah, I
Hmm.
saw somebody recently who was coming in for pain, right? And got a deficogram that said rectocele, cystocele. I think it said all the things. And on
Hmm.
physical exam, she wasn't bothered by a bulge. She had no bulge, splinting, voiding dysfunction, and it was not bulging on exam. And she really was hoping surgery was going to be the fix to the pain. And it's like, for those people, I'm like, I want you to see a surgeon who's going to say, no,
Hmm.
no prolapse repair is not going to, let's address your pain, get you into physical therapy, see what's going on. But fixing something that's not clinically there likely is only going to make it worse
Worse.
or the
Hmm.
same. And now you've
Yeah.
gone through a surgery. So really
Yeah.
finding a surgeon who says no to a lot of surgeries is a good thing.
Yeah, and I will tell women too, if I say no and they're super disappointed, I'm like, honestly, if you go see another doctor, you might find someone who's willing to do this because there are those types of physicians out there, but I hope that you trust me enough to realize, like, if it was, I'm a surgeon, I like to operate. If there was something worth fixing, I'd fix it, but
Yeah.
I don't want to hurt you. I don't want to make it worse.
Yeah, I love that. Well, thank you so
Hmm.
much for giving us a comprehensive prolapse discussion. It needed to happen. Prolapse is way more common than it gets talked about. And,
Absolutely.
we all have the babies with the big heads. Let people
Vaginal
know where,
bypass.
I know, vaginal. I love that. I am stealing that. Let people know where they can find you. And I'll put it in the show notes, of course.
Awesome. I am located in Deer Park, Illinois, suburbs of Chicago. My practice is called Allure Pelvic Wellness. Yeah, and I'm on social media and I have a website, www. So you can find me everywhere.
I love it. Thank you so much for joining us today.
Thank you for having me. This was fun.
It was fun.